The healthcare dynamic is rapidly changing. Understanding the basic fundamentals related to the business of medicine empowers practitioners to advance their skills in and knowledge of the business aspects of medicine. SMA's Business of Medicine Simplified program explores the essentials of everything from reimbursement and compensation models, insurance and risk management, to practice employment and business finance.
Hello, everyone. My name is Andy Mohan, and I'm the chairman of the Division of Digital Health and Innovation for the Southern Medical Association. In light of the current crisis, the next several podcasts are going to be focused purely on COVID-19, with interviews from various experts of different fields of healthcare and technology, since it's the utmost topic on everyone's mind at this current time. I hope you are all safe during these very difficult times in which we have been asked to socially distance ourselves from others to combat the spread of this very dangerous virus, for the protection of the most vulnerable, and to flatten the curve so that our healthcare systems and clinical personnel are not overwhelmed with patients. With this in full consideration, we have a star expert and leader in technology to kick this off. But before I introduce him, I want to introduce our one and only Ms. Jennifer Price, who's our educational manager here at the Southern Medical Association, and our moderator along with myself. Additionally, we have with us today Dr. Deepak Mohan, who will also weigh in on today's topic of discussion. He is currently the Medical Director of Pathology and Laboratory Medicine and Associate Professor in the Department of Medicine at San Joaquin General Hospital in Northern California, and is on the front lines of this growing pandemic. He's a well-published pathologist with several publications in his field. Dr. Mohan is a certified College of American Pathologists inspector and serves as a team leader for numerous laboratory inspections. He is board certified in anatomic and clinical pathology and has presented his research at various national meetings and has published numerous articles in peer-reviewed journals. Dr. Mohan received his medical degree from the prestigious Madras Medical University and performed visiting clerkships at Harvard University and the University of California at Los Angeles. He has completed his anatomic and clinic pathology residency training at the University of Pittsburgh Medical Center, followed by his fellowship in surgical pathology at Cedars-Sinai in Los Angeles. Thank you so much for joining us for the discussion today, Dr. Mohan. We have an absolute treat for you today in terms of our chief guest, Mr. Aneesh Chopra. He is the president of CareJourney, an open data membership service building a trusted, transparent rating system for physicians, networks, facilities, and markets on the move to value. He served as the first U.S. Chief Technology Officer under President Obama from 2009 to 2012, and in 2014 authored Innovative State: How New Technologies Can Transform Government. He serves on the board of Healthcare Cost Institute, the New Jersey Innovation Institute, and earned his MPP from Harvard Kennedy School and BA from the Johns Hopkins University. Thank you for joining us, Mr. Chopra. It is truly an honor.
So I just want to take this opportunity to thank Dr. Mohan and Mr. Chopra for joining us today and during this time. And I'm just going to go and start with the first question for Dr. Chopra. Dr. Chopra, first of all, I just want to get your bird's eye view thoughts on this current crisis pandemic. How are you dealing with it? How's your family? Give us your thoughts on it.
Well, thank you for asking. I think all of us are grappling with this on a personal level. We're adjusting our lives and attempting to balance social distancing with expectations and norms. We have kids in the house. They're 5, 11, and 13, and trying to figure out how they can play and study and be productive in this new moment in time. It's actually helpful on the educational side. We're having conversations about what this moment means, but obviously very difficult, as I'm sure every family is grappling.
So, Dr. Mohan, do you want to comment? How are things going for you? Is it pretty similar? I know you have kids as well, and would you care to comment on that as well?
Yeah, I echo the same sentiments. We're all grappling with this because this is all new to us. I have a daughter in high school, and she had scheduled for an SAT, and in fact, the SAT was canceled. And well, she's obviously concerned about her future and how her college applications and all that process will be shifted based on what we are facing today in current reality. So every human being on the planet, I think, is facing this, and each one has their own concerns, and for obvious reasons, this is something that will change our lives, and we'll definitely look back at this moment and realize that this is the new normal.
Yeah, these are pretty difficult times. You know, just there's so much going on. It's so difficult for the children, and we're all going to have to bear with this for a little bit of time. Mr. Chopra, so what's your take on technology currently to support patient care amidst everything that's going on? What do you think we'd be doing better from a provider and a patient perspective on the ground?
Well, I'm paying attention to three things, and I'm working in a collaborative fashion with the administration. This is an all hands on deck moment, and I think there are three areas we're going to have to kind of get right. And I'm going to describe them in the context of just ways in which we can do better than the current model. Obviously, let's assume on the front end that we want to make sure everyone's interaction with the healthcare system renders the best possible decision making, and that the execution of the clinical intervention is at the highest standard. That's sort of a given. The three things I'm focused on are: one, democratizing access to more trusted, open data. And what that means, in my view, are three things. One, we want to make sure that simple information about where to get tested, what does it look like, however you go through a process to engage the healthcare delivery system, we should do a good job of informing you of all of the available options. And that's essentially a search problem. How do we find the relevant information that's pertinent to us and our families? And I'll talk a bit about what the strategy might be for that in a moment. Second, how do we capture as much of the real-time surveillance information about who's at risk, who are the carriers, what are their, do you have to be symptomatic or not? We've learned a lot from Wuhan and Italy. How might we begin to harness, now that the numbers are unfortunately growing in the US, how might we complement that international research with more local, perhaps more granular information? Are there other comorbidities that are at greater risk than others? We should be studying that information, especially a decade in to all of the digitization in healthcare. You'd think we'd have a richer understanding about the nature of the disease and the opportunities for intervention. The third area of trusted open data, in my view, is a bit more long-term. We don't know what does it mean to be COVID positive, but then to recover. Does that just mean hunky-dory? We're okay? Do we want to ongoing monitor patients who sort of were COVID positive for ongoing changes in health status? How might we think about that concept of a Framingham study for the COVID community, such that we understand over time the implications, and that we don't wait decades to respond, but we are hopefully taking much more proactive care given the changes on the ground. All of that, to me, are areas in which the public sector and the private sector to work better to remove barriers and to accelerate the democratization of information. The second area that I'm anxious about is we have a public health surveillance system today that relies quite heavily on faxes and phone calls. It's not like our local health departments are sitting on the fanciest new technologies. And so we've got to modernize. There's a tweet on the day that we're recording this podcast, a commentary from an ER doc, I think in Southern California, who complained that it's taking an hour or so to complete the CDC's case report forms. Now, that may have been an exaggeration and a frustration, but it speaks to this issue of modernizing the public health reporting infrastructure. That, to me, is bucket number two, because we are all relying on that infrastructure to help inform and allocate much needed resources. Third, and certainly not last of all, we want to make sure that the delivery system itself is prepared for a digital first model. The news announcement around the waiver of some of the HIPAA barriers, specifically the need to go to a vendor when you want to text a patient or call a patient or video chat the patient and pay what many might believe to be exorbitant fees relative to the free services and Skype and FaceTime and everything else. Remarkably, a powerful decision by the HHS team to waive a lot of those enforcement obligations, so we can start to democratize a digital first model. And by the way, we might come out of this thinking like, why don't we do this regularly? And so hopefully it may be, on the positive, if there is any, a chance for us to kick the tires on a new way of practicing medicine. But those are the areas that I'm spending my time and attention thinking about, and happy to go deeper on any of them with you today.
Dr. Mohan, do you have any comments in terms of what Aneesh, Mr. Chopra brought up just now?
No, I think it's a very excellent overview of the technological barriers that we've been having. I think the elephant in the room really for this particular crisis, as far as the testing, because we brought that up as far as where you can get a test. There are some issues, and I'd like to go into that as well, because that is my area of expertise, is laboratory testing. And some of the biggest barriers were based on only a single source of testing. Initially, the tests were only available through the CDC. They were very quickly overwhelmed, and they did not have enough test kits, and there were some failures as far as the test kit manufacturing process, the primers that they used, not getting into too many details, but the primers that they used on the first kit that they sent out was flawed, and there were some discrepancies when the validation process was taking place. So that was a breakdown. In fact, we could have done a lot better as a country in that. And in fact, if you look at South Korea and China, they did much better in the testing phase, mainly because they didn't have all the barriers that we had set up through the FDA and CDC on getting the testing up and running. We're finally catching up as far as testing abilities, mainly because the CDC test was a fairly manual test. And even though it's a PCR assay, it was, you're very limited in the number of tests that could be done per day. Now, with the entry of Roche and Thermo Fisher and some of the larger companies, we have high throughput testing, which will allow us to do 5,000 tests per day on a particular instrument. And if you have multiple instruments, you could do, if you have 10, obviously 50 or 500,000 if you have 100. And those instruments are out there in the United States. So if those kits get out to the right people, we could have very easily 1 million tests a day now that the high throughput testing is available. But there was that barrier, that phase from day one to today where it's now widely available. Why did it take this much time? That question we should ask ourselves, not for this crisis, but for the next one.
I couldn't agree with you more, and I kind of skirted, as you can imagine, in my remarks away from what has clearly been the Achilles heel. That's more of a political statement about how and why that I'll leave to the talk shows in terms of who to blame and what happened. But there should be a thorough and thoughtful examination of the failures here. They're not all political. There must have been some operational breakdown, and it is a tragic statement about our lack of capacity in the testing domain. It is not my area of expertise, and so I'm more of an observer in this commentary than anyone that's got an informed reason as to why, but it is frustrating.
And the funny thing about it is not just lack of capacity. The capacity existed. It was the artificial regulations that capped the capacity. If there was faster movement, and let's say we were talking about Roche getting this test in, let's say, late January, we would not be in the situation we are in right now. So we lost about a month and a half, 6 weeks from what we could have moved. We should have moved the moment China had this outbreak and we knew about it, which was probably around New Year's time.
Yep.
We should have started the EUA process, which is the emergency authorization process through the FDA, and we should have been able to have a few tests available from the large manufacturers by early February. But I would say we're about 6 weeks too late, and that's 6 weeks may be a problem when we look back on this, what we could have done better. When we talk about flattening the curve, that may be the biggest factor in not being able to flatten the curve fast enough. And we'll see. Only time can tell with these type of things. As of today, I think there was 110 deaths in the United States. So that number continues to go up fairly rapidly. Hopefully we don't end up in a Italy situation. I don't see ourselves in the South Korea situation. I think we should be somewhere in between Italy and South Korea. Hopefully we're closer to the South Korea paradigm than Italy, because Italy is a disaster.
Yeah, well, look, and I couldn't agree with you more, and it is a befuddling and frustrating circumstance. To the extent that it's possible, I think it would be very helpful if you, stayed on that subject about testing and testing options. There's reports all over the world of new approaches to testing that may not necessarily be PCR based, and again, it's a bit beyond my expertise, but we do need to find a way to summon up the creativity of the country to get going.
Absolutely, that's a great point that you bring up. And PCR is obviously the most sensitive, and you eliminate the window period that you have before you. The other form of testing that we have is antibody testing. And the thing with antibody testing is you have to form the antibodies, and there are some that will never form antibodies because of if they're immunocompromised or such. But most of us will form an antibody, but there's a window between the exposure to the virus and the antibody forming. And that's the limitation in antibody testing. But antibody testing can be very, very inexpensive. That really is where the benefit is, antibody testing. And it can be as easy as a home pregnancy test. In fact, there is a company out in the United States that's not quite FDA approved, but has submitted an EUA on antibody testing. And that would be available probably within the next couple of weeks. And when we talk about the simplicity of it, it's a matter of taking a drop of blood, placing it on a cartridge, and dropping a couple of drops of buffer, and you get a line if it's IgG or IgM, and based on that, you'll know whether there's exposure to the virus. And this could be good for populations that may have been exposed and not showing symptoms, and this way you get an idea of what the exposure rate is, and it's not as expensive as a PCR test. And my question to you, Mr. Chopra, is mainly with all the technology that we have today, what would you say is the most important technology that we have to get us out of this crisis that we didn't have 10 years ago?
Wow. When you put it in that term, I think it's going to sound silly, but the social distancing, if we're going to flatten the curve, the only way that happens if people change behavior. And so think about all of the nudges that have affected our lives to click on an ad or to watch a show or to, eat at a particular restaurant. And imagine if all of that horsepower analytically was geared towards helping drive people towards more thoughtful social distancing, and we could in fact contain the pace of this thing spreading. I don't know, what it took to convince those kids that we saw pictures of over the weekend partying on Bourbon Street, and the blasé view, it appears, of people not taking this issue as seriously as perhaps we as a country need. The more we can apply these communication and nudging techniques to give people some purpose around taking these recommendations seriously, I don't think anything beats this sort of social distancing strategy, and the degree to which it works, sadly, I don't know if you were to distinguish the Koreans from the Italians on how seriously they took this stuff, but irrespective of their pace of testing, I would imagine that they had done a much better job of getting the behavior change in the community. Now, maybe it was done by fear and political efforts, but if we could use these technologies, if we were constrained in the box of tools in the toolkit to be a technology tool, I would say that the nudging and the decision support to get people towards believing that social distancing would work and to get them to do it is probably the most important public health intervention today. I don't know. I'm not an expert in public health interventions, but that would be where I'd put my energy.
Well, now, another interesting question I'd like to ask you, obviously China, because it's an authoritarian regime, is able to do certain things that we certainly could not do in our society. And some of the things that they did in China was tracking the cell phone and seeing different areas where people may have visited. Do you think we could adopt some of those where we can anonymize the data and possibly use that to possibly track people and at least to keep people from not spreading the disease as quickly?
Herein lies a fault line in the American economy. So about 3 or 4 years ago, that type of tracking technology was sold on the open market in this country. Your cell phone carrier would sell the rights to use the anonymized data streams. And there were, I'm sure, infinite commercial use cases of the data. So it's not like we were just sort of completely honoring the spirit and letter of privacy rules. We had viewed the de-identification process as some kind of massive loophole if you take it from that perspective. And we saw, we do, by the way, see this in healthcare today, just as we talk about this in the cell phone domain, where once you de-identify something, it's no longer subject to regulation, generally speaking. And so the commercial the economic models kick in. So it is of the case in the same way we read about the God mode in Uber, if you remember, where service providers actually have this sort of commercial right to kind of take this kind of information and disclose it, that we may have a private sector sort of kind of effort to kind of shame or identify poor practices in the practicing of social distancing. I don't know if the government will be driving that in the US. We've got pretty strict laws against some of these things, and our ethics and values towards freedom really make that an intervention that's only in the most extreme of circumstances. I don't believe we're there yet. I think that the ability for us to identify the fact that people are not practicing social distancing in the commercial sector may be the next round of reports to be published. Some data holder that has rights might work with a media company to kind of highlight the fact that in certain cities in the country there's a lot more gathering than there should be. I mean, these new rules about don't gather in communities of 10 or more, who's to say that the cell carriers can't disclose some of that information because they have it in their database? And so that's an open question, an ethical question. Will we see private data sources disclose this sort of naming and shaming? I don't know, but you're right. Countries around the world that believe in democracy and those that don't are all thinking about this issue of the trade-off of privacy and public health and safety. And I just don't believe we're there in the US to cross that line yet.
Thank you. That was a very thoughtful response. I want to shift gears a bit here and ask you about something. In fact, this morning, all of our meetings went to Zoom. And so now we're all practicing social distancing as far as our meetings. And some of our surgeries have been canceled as well. And all elective surgeries have been postponed. So obviously we do have some capacity to do robotic surgeries. and the promise of, let's say, 5G technology was being able to do that more often. How close are we to realizing that potential of 5G? I know that we were maybe a year away or closer, but is there any possibility of hastening that process so that we have 5G technology quicker?
I generally am of the view that the capacity for the technology will exceed its demand for the kind of applications you're thinking about, and it's not going to be a technological barrier that will slow it down. So when you break down the technical requirements for some of these distance procedures, I'm not so sure you need the bandwidth and the resiliency and some of the radios that are involved in 5G. We can do a lot in the environments that we have. We're just not organized from a variety of fronts to do that. I'm not so sure robotic surgery was first on the list of things to happen in a 5G world. I think there are probably a number of other use cases that may exceed those, but in general, we have many more non-technical barriers to the uses of these capabilities, even in our current form. I mean, here we are discussing robotic surgery over 5G, and what was the big rule announced by HHS? That you're legally allowed to use FaceTime to talk to your patients without violating HIPAA. So, you know, it's a tale of two cities here on the nature of the question.
Well, my next question is based on what you just said. Maybe we should be talking about broadband access and getting access to small towns and school districts that may not necessarily, they may be closed, but they may not have the broadband access to be able to do classes online and that sort of thing. That might be more important than robotic surgeries.
Thank you for that. I was sort of, not to be skeptical about the pieces you're describing. I just, you know, I appreciate as the former US CTO, there's always a sort of a tech bias in the nature of questions and conversations. But I find my personal bias to be quite the opposite, which is to put more emphasis on the problem to solve and less emphasis on the capabilities of the new and emerging technologies. One has to be aware of the possibilities and play a form of match.com after having done a thorough evaluation about the nature of the problem itself. And so I would say, if I were to rank order my risks as it relates to this sort of technological question, it strikes me that the greater risk is the at-risk senior who has health needs, but the price of going to get those needs cared for in person in a hospital setting or an ER puts the price, the cost-benefit equation out of whack. So the underserving of the addressing of the clinical needs for the at-risk population that chooses, rightfully so, not to engage the system, that's where we're going to put some energy and emphasis. And that's both broadband access, which is, do I have the connectivity? It's also do I have the devices? It may sound simple on this podcast for us to presume everybody has a smartphone, and thankfully, smartphone adoption exceeds what you might traditionally think of as wired broadband adoption. However, there still is a sizable part of the population. In fact, it's the sizable part that probably disproportionately accounts for those at risk that we need to address right away. So I'm envisioning in the not too distant future a set of big tech announcements around allocation of smartphones and other devices that could enable at-risk seniors in particular to stay in place and to get their issues cared for, at least the medical issues that may be addressed through pharmaceutical means as opposed to surgical intervention.
Very good. You know, to that point, when you're talking about the security and, you know, when you're talking about FaceTime or whatever it is for that deregulation, do you think we're ever going to go back to where there's that heightened level of HIPAA security, or is that security now it's deregulated and people are going to be using it during this kind of, you know, this pandemic and this this current situation? Are we going to be going back, or are we going to stay status quo now? And is this the new norm for that type of security?
Yeah, great. Yeah, I love the question, and I'm generally a third path guy. So are we going to go all in backwards? Are we going to go all in current state? Reality is we're going to find a new normal, which is that the publicly available resources that don't require a vendor middleman to add some hyper magical HIPAA formula can actually accomplish a great deal of the privacy protection it was intended to meet without the minutia of the kind of regulatory process. So what happened today, just to, if I may, just to take a step back, because I'm imagining listeners to your podcast might have this visceral reaction when you say sort of HIPAA, yuck, and what is this thing, and how dare it way? And I am super empathetic here. What actually happened in the regulatory world, and I think one of the reasons why we have so many problems is that we basically have I don't want to go back to whatever, I forget which justice, was it Justice Brennan, who said something about pornography is based on what I see. HIPAA security is based on what your CISO sees. So the rule basically says, and again, I'm not a lawyer, but I'm going to just describe it in layman terms. You must take precautions that information sensitive about a patient's health status not be accessible to parties that are not intended to know said information. That could be other doctors in the hospital that should not be snooping on my patient's records who they have no relationship with, even though technically their EHR allows them to do that search. It means, neighbors and passersby shouldn't be able to hear about this sort of information, and it certainly means nefarious hackers shouldn't be able to easily access the information. These are not crazy ideas, right? You would generally want a relationship in our society where we would treat this sort of information in a respectful way. I don't think there's anybody that would disagree. The problem is that in the rule, we basically said you have to conduct your own risk assessment. And you have to validate that you've done a risk assessment and that you are implementing that assessment and mitigating the risks that you see that remain outstanding. Well, if I'm the lawyer representing hospital X, Y, or Z, and I'm responsible for a risk assessment, what is the risk of someone on FaceTime having that chat result in someone learning about your health status that wasn't meant to learn? You can't say the risk is zero, so you say a risk. And then the minute you say a risk, you can't just then use it. You have to take steps to mitigate the risk. And then vendors show up and say, no, I'll HIPAA secure FaceTime. We'll call it HIPAA time. And pay me X $100 a month and I'll give you HIPAA time. And so people feel like, okay, I'll pay HIPAA time and I'll, then, whatever those risks were, even if it was overkill and I'm paying way too much to mitigate the threat, it's what passes my security review. And so we're going to do it. That mindset is what's going to change with these rules. So we're going to learn what is the true risk of the disclosure of this information, and whether on these commercial off-the-shelf tools, we can take meaningful steps to mitigate those risks without having to go to vendor HIPAA time. And I think that's where we're going to land, and it's going to err more towards freedom and less towards bureaucracy. That's my hope.
Okay, I have a question for you. Since obviously when you were with the Obama administration, you oversaw the EHR transformation that took place over the last 8 years. And there was a lot of promise about EHRs and how, a situation like this, there could be syndromic surveillance with AI technology and connectivity between the different EHRs. But that quite hasn't happened. Why hasn't it happened, and will it be happening in the future based on this crisis?
So that is a billion-dollar question, and it probably merits a little bit of a response in context. So let's go back to the promise. The theory was digitized records available where needed, when needed, should result in, at a minimum, a reduction in duplication of testing and waste. At the maximum, to enable analytics that could result in smarter decision support. So we would know more about your condition sooner and that we could treat it in a more effective way than maybe the reactive, haphazard way, fragmented way most people interact in the delivery system. That was the promise. And there were price tags, billions of dollars of savings, expectations, and the like. Now, there had been adoption of electronic health records, but the problem they were trying to solve, sadly, was mostly one about documentation and revenue cycle improvement, and a little bit less about quality and aggregation of the data and the decision support to nudge patients regardless of where they hit the delivery system. And that really speaks to the economic incentives at the time that were driving decisions about go, no go on IT. In a fee-for-service world, perversely, you'd rather not, and I don't mean this in a pejorative way, but economically, your incentives are to not coordinate the care because each duplicative test is revenue. Each failure to have prevented the disease results in a procedure that generates revenue, and on and on and on. So what we had at the time was a sort of a visionary promise and academic theory of the case. We obviously knew for that to be fully realized, we needed an economic model that would drive that use. So we had the following conundrum, and here's how I would describe it. We had two landmark healthcare pieces of legislation travel in the first, call it 24 months, the Affordable Care Act and the HITECH Act. By virtue of the economic crisis, the HITECH Act preceded the Affordable Care Act. In the Affordable Care Act, we put the placeholder that we would move the country towards value-based care. And that created ACOs and financial incentives and the authority to gain share and a variety of things that when those things scale, you would naturally see the delivery system demand the kind of technologies and applications that would do the very things we had hoped would be done at the start of this program. So acknowledging that the fundamental incentives of the market did not change on day one, when we wrote the $30+ billion check, it was obviously going to be a journey that required us to make some aggressive moves early, even though they were not wanted or needed, but we felt were critical placeholders for a future delivery system that works. And if you indulge me for a moment on one example, and then I'm giving you a sort of a soliloquy here. John Glasser, the famous Chief Information Officer of Partners, whom I love and respect, told us early in this Recovery Act program that despite 30+ years of history at Partners with electronic health records, he could not produce a list of patients at Partners who smoke. And if you're thinking about public health interventions that would keep the system, drive value towards the system, identifying smokers, routing them to smoking cessation programs, getting the public health and preventive services right would be among the first steps you would take to deliver true population health. And if you can't produce the list, how are you supposed to do that without it being a massive burden? So we required a bunch of data elements be collected in the initial stages of the HITECH Act. And a lot of doctors were frustrated. I'm a psychologist or a psychiatrist. Why do I have to record my patient's blood pressure when they visit me? Well, the reason is, if we went to the VA was tracking an outcome measure, the percentage of hypertensive patients that had their blood pressure controlled, and they were in the mid to late 20s, if I'm going by memory, in one of the VA markets, the DC market. They applied a universal intervention that doesn't matter which practice you came in for a clinic visit, including mental health, you would get your blood pressure taken every single time. they skyrocketed to something like 75% of their patients that were hypertensive that had blood pressure controlled. And the single biggest referral source to primary care for adjusting medications was mental health. Patients that were coming in for counseling, got their blood pressure checked, had elevated blood pressure, were referred into primary care, adjusted their meds, and kept them under control. That saved countless veterans. But who was demanding that blood pressure be data entered by a psychiatrist in their purchasing process? And so that is sort of a kind of a microcosm for the collective action challenge that we've had in this move to digital records, if that is anywhere remotely answering your question.
Thank you. I think that's a very thoughtful answer. Moving on towards the tracking the virus and other aspects of that, do you think there could be a good way of maybe developing an app or a web-based method to do that? I know that Google was supposed to be helping with this effort. Should it be something that should be more of a government effort than a private sector effort? And why haven't we already put this into place instead of waiting for a private entity to produce this?
Yeah, again, a great question. So let's just break that down into 3 parts because it speaks to some of the early comments I made. The Google effort was largely designed to help be a triage and testing locator service. That effectively is call it the shopping experience, for lack of a better term. And as we scale up testing, and your points were spot on about the frustrations of the current, delay and problem-laden testing system we have now. But as the new capacity comes online, how can we effectively triage people who are struggling with whether they should or shouldn't get tested, and to route them to the nearest location that's useful, that's available for these sort of drive-through, minimizing harm and maximizing the right answer. That to me there's likely going to be it's a yes and. There'll be a government site presumably, and there may be a number of private efforts to educate you on how in my neighborhood you can get drive-through testing at this church. An important step for the public health community is to allow and manage both. So I hope we'll see actions that are both the operator of the testing location system as well as the regulator to make sure that people that assert that they're building these sorts of commercial apps have some rigorous quality control on their algorithms, and that the potential to disclose all available testing sites, not just those national chains that might appear early in this process to appear. That to me can be done public sector, private sector, or both. Where you're going on the research question, if I think I heard you correctly, it is more likely the case that we'll see private, what I'll call longitudinal patient registries. Rush University Medical Center has already announced that they've got IRB approval for one that they're organizing in Chicago. There may be many others that join forces with them or work in collaboration. Maybe the government plays a role in tapping into that feed for research or helping to underwrite some of the infrastructure. This will be public-private, and it won't be about government's better than the private sector or vice versa. We got to move past that sort of artificial divide and move to a world where problem solving will be much more effective and scalable if we optimize the public-private interface. If we had a national standard for triaging who should or shouldn't get the COVID test, it'd be nice to know that the app I'm trusting on my phone to do that pre-screen, maybe Babylon Health has one, maybe others do, is adherent to some standard, and that I can trust that it's not going to, lead me astray. That is a public-private relationship that I hope we're going to see more of in the response to this crisis. So from the non-PHI, non-patient-specific data sharing to the specific patient comorbidities and research databases, all across the board, we're going to need a mixture of public and private.
To that, I want to just take a little segue. You're the current U.S. Chief Technology Officer announced an AI data challenge that is similar to the previous challenges we've launched, or you guys launched with the Obama administration.
Yep.
What are your thoughts on AI data challenge? And for our listeners too, what is that specifically? What does that mean? That was proposed, and how is it different from what you launched, and how will that those differences potentially affect us?
Yeah, so the first point is, in the Obama administration, we wanted to expand the toolkit for problem solving. In the old days, the government had to either do a procurement and buy a solution, or it would sit back and watch the private sector design its own solution. Maybe would set rules on the road and create some regulations here. But the universe of options for how we can drive, more innovation directed at a particular set of problems, that one had a lot more limitations. So in the American Competes Act, the reauthorization of that back in 2010, we asked Congress, and Congress gave us explicit prize authority that allowed us to issue these calls to action, these challenges. There's a website, challenge.gov, by the way, that inventories a lot of them. And it really broke up a lot of the historical barriers that had gotten in the way. So, if you're trying to develop a novel testing kit that's not based on PCR, but something else to look at the antigens, and you wanted to do that in a timely manner, you might imagine, although that did not happen here, you might imagine a challenge that could be posted that offered $1 million reward for the team that accomplished the goal of doubling the response time, cutting in half the error rates, and doubling or maybe by 90% reducing the cost of administering the service. Putting out the goal, the objective, the measurement criteria. Now we can do that and pay the winner, as opposed to RFPs that you think on paper this is the best team, and then in reality they don't know what they're doing. So what did my successor do? The US CTO announced, I think earlier this week, that he convinced all of the journals, the scientific journals that normally take long cycles of keeping the data proprietary, the articles on their sites require you to pay fees to get access in a timely manner, that somehow we would embrace this more open philosophy on a subset of those publications. And so he appealed to the community and said, look, can we get more content in the public domain? And that was pretty successful. I think we got 20,000+ research studies in a preprint open source model. Then the question is, who's going to read 20,000 articles in a day? Well, maybe Watson or some other artificial intelligence partner. And so the administration launched this challenge to help us mine all those articles to see if there are clues about how to mitigate the risk or how to manage it to the extent that you become COVID positive. That is, an area that aligns beautifully with what we used to do in the Obama administration. Obviously, it's a different era, more technology. There was not the same kind of artificial intelligence capacity in the country. Now that's a lot easier for folks to do. So there are differences in the challenge for sure. But sort of philosophically, I love and applaud the administration for doing it, because it speaks to that need of public and private collaboration. My hope is that we'll see a faster turnaround of novel risk factors that we could take into consideration immediately, and to help people avoid unnecessary exposure in the days and weeks to come. So that's what I'm hopeful will come out of the challenge.
I have a kind of a comment or a interesting thing I'd read this morning about usage of technology and the 3D printing technology that exists out there. Apparently, there was an Italian hospital group that required a particular filter for the vent, and this particular piece they were not able to get in quantity, and it was very expensive.
Yep.
So they decided to launch 3D printing to be able to print this part, and it worked beautifully. And the only thing is that the company came back at them as a patent violation. Should we be suspending those type of activities right now, especially in light of this crisis? I know America is a capitalist country, but at the same time, when you have a crisis like this, shouldn't we all be pulling together instead of trying to gouge and try to make money off the situation?
Well, everything should be on the table. And every individual decision about a regulation to waive, intellectual property rights to earn, we must acknowledge that there are trade-offs in every one of those decisions. Without knowing the specifics of the case and to what degree the patent holder is operating more as a troll as opposed to someone who's trying to go to market with a similar product, but under fair circumstances, I think those things matter when you ask questions about protecting intellectual property. But by and large, we absolutely should look at all options to accelerate the much needed testing and the much needed capacity generation on ventilators and other assets that could be produced. I don't know what was produced in the 3D printer, but to the extent
it was a part that they needed as far as to change every time a new patient came for a new ventilation. So they had to change this filter part, and there wasn't sufficient filters in the market. They couldn't find any, and in fact, they went to the company and they said it's back ordered and so on and so forth. And so they went ahead and printed their own. And the company was very slow to respond when they needed it, and then all of a sudden they became very interested when they found out that they were 3D printing the same part.
Yeah, no, that is definitely. I mean, again, not knowing the details, that'd be a great candidate for sort of emergency use for this purpose only, and that they can't over time, build a competing product that strips away the intellectual property. There are mechanisms in place for those kinds of things to be protected. I wouldn't call them fair use, but you could think about a framework like a fair use. That is to say, I have the right to build this part for a product that I've been using in a crisis. And so, yeah, I think everything's got to be on the table. And the good news is we don't need an act of Congress to change that. There are executive authorities here and social norms that we could work on to make a difference.
Mr. Chopra, I know that your time is valuable, and we could sit here and talk to you on this podcast probably for forever. I mean, it's just the amount of knowledge and insight you have is just it's amazing. It's mind-boggling. I do want to ask you something about the company that you're president of, CareJourney, and you would care to talk about that a little bit and how that potentially relates to COVID-19 and what's going on right now.
Yeah, thank you. I'm generally, sheepish about sort of promoting my own things, and so I appreciate you saying that. Just briefly, my theory, going back to this moment we're in healthcare, where we try to rein in healthcare inflation. If the country can get healthcare inflation to GDP plus 0, we free up a lot of resources to do a ton on a broader competitiveness agenda. So I have to acknowledge at the front end of this, my overarching goal, which is to help the country get to GDP plus 0. To do that, my theory of the case is that we've got to shine light on what works today. We need more data transparency. We need the, kind of a little bit more surgical, not broad brush intervention. So this cohort of people should get this type of intervention. And if enough of these cohorts get the right intervention collectively, we might achieve pretty sizable savings. And then third, that we have some feedback loop, some mechanism to kind of reward best practice or the routing of patients more thoughtfully through the system. So if you think of those three things, they're fundamentally a data problem, and in many ways, they're a big data problem. And so at the source of a lot of this is the fact that the government itself is the repository for a lot of the information you need to measure these things. The Medicare claims database, in my opinion, is one of the most under-leveraged resources to understand what works and what doesn't in healthcare. And up until the Obama administration, it had been illegal to access and use that information, especially for commercial applications. So we, CareJourney, the company I am president of, are kind of a merry band of fellow travelers who believe that if we can tap this data set or these data sets, we can democratize much faster information on what works and what doesn't, and to route people more thoughtfully through this complicated delivery system. We have a license to the National Medicare Database that includes access to Medicare Advantage encounters and Medicaid encounters. It's about 120 million unique Americans have linked longitudinal claims history that our researchers log into CMS every day and mine to find out what works and what doesn't. At the core of what we do is establish some type of benchmarking system at the physician level to know, all else being equal, which primary care doctor is most likely to treat people like your mom in the most cost-effective way possible at the highest possible quality. And we are building a cost and quality outcomes scorecard for every doctor in America, not as a punitive measure, but as a way to educate networks on how they can improve, to align with those that take financial risk in terms of who they'd like to recruit onto their teams to help manage those populations, and to fuel both physician and consumer-facing applications that can incorporate that information to make smarter decisions along the way. We have over 50 members. Most of them are health plans or health systems, and a few technology companies. But the goal is to democratize access to this information. We have an open model. Members ask questions, we run research, and we disseminate the results widely, all on publicly available data. So thank you for the opportunity to share a few words about what we do.
Absolutely. Is there anything else that you would like to talk about that we may have missed, Mr. Chopra, that you think that our listeners are providers as well as patients? So is there anything else that you'd like to add before I go to the final question for both of you guys?
Yeah, my one comment I would make briefly is that more than anything else, we need a mind share change. We in healthcare today are too fixated on each individual. How does pharma react, and where do the physicians stay, and what's the hospitals doing? And surprise billing is a sort of a wonderful embodiment of this sort of silly season on how to care for people. And so to me, the mindset that needs to change, and I hope with these new regulations we'll get there, we need people who have what is equivalent to a digital Hippocratic oath, that no matter what happens, whatever I'm going to be doing is in the best interests of the patient, not the best interests of my organization within my silo of this part of the healthcare delivery system. And that's not a technology issue. It's not artificial intelligence. It's not 5G. It's culture. It's mindset. And if we can disseminate more of that thinking and elevate the bar to a fiduciary-like standard as we leverage all of these emerging technologies, I think we're going to see a much better system for the people we love.
Oh, I love that. Digital Hippocratic oath. I think that's a great concept.
The last question I wanted to ask you is basically, I wanted to ask both of you gentlemen, what's one pearl that each of you guys can give our communities, healthcare personnel, patients, and listeners. I think that kind of summed it up with yours, Mr. Chopra, unless you wanted to add something to that.
No, thank you.
Yeah. And I think, unless you have something else to add to that, or Dr. Mohan, what's one pearl that you would want to give our communities, healthcare personnel, patients, and listeners during this time of crisis?
Well, first of all, I'd like to thank what the healthcare workers have already done, and I also want to thank them for what is coming our way. The next couple of months are going to be rough, and there are going to be moments and times that we're going to need an ear. And just because it's social distancing doesn't mean we can't call up our brother or a sister or a mother and give them a call and talk to them. Because sometimes we think about social distancing and we think about the proximity of the person to us. But because we live in a digital world, we're all connected, and we can leverage the technology that exists and be as close as right next to each other within a meter, but without being that close.
Well, and I just want to thank you so much for both of your time today on this podcast. I look forward to a brighter future for all of us during these times. And I think if we come together, then we're going to be better off. So if we collaborate and get things done globally, I think we'll be better off for the future for us and our children. So I just want to say thank you so much for your time, and I appreciate it. And we all appreciate it very much.
Thank you for having me.
Thank you again for joining us. To subscribe or to listen to additional SMA podcasts, please visit sma.org/podcasts.